All right, ready? Just show the shots.
All right. Jaffer, it's Eric. Can you hear me?
Yes, we're good to go. You guys can hear me?
Yeah, I think we're going to try and get this next session going after the break. People are still filtering in from the exhibit hall, so why don't you go ahead and show us what you have here, and we'll wrap this case up.
Great. Thanks a lot, Eric. We're going to just wrap up in about 30 seconds. 2 points I want to make. One is I forgot to introduce our illustrious anesthesiologist, Dr. Bhopal. He's done a phenomenal job, and he promised me he would turn off the beeping sound on the pulse ox, so I really appreciate that. So what we did is, there was that one spot there in the distal reentry zone where we had a lot of fibrotic tissue. I really don't like stenting. However, the distal reentry zone is the spot that is going to most commonly restenose. So that's actually after ballooning. So if that spot even hiccups incorrectly, then I will drop in a stent at that distal reentry zone. Let me just show you a couple of things right here real quick. This is after balloon. So let me show you what it looked like. That's the distal reentry. We had sluggish flow there, you see that?
Yeah.
So what we did is I initially went back in through it and did a regular balloon, then a drug-coated balloon, and then we still had some haziness there and some recoil. So what I did is I put in, it was in the distal SFA proximal pop, so I put in an Everflex 50 by 120 millimeter stent, excuse me. And let me show you what our final result was. And then we post-dilated with a 50 by 100 balloon. And this is our final result here. So that looked good. You still see that external compression.
Yeah.
But let me show you our final injection here, and we'll break away so that Miguel can come live. But here we go. 1, 2, 3. Beautiful. That looks good. So hopefully we demonstrated for you guys a very complex case today. We had great results. We use ocelot. We use drug-coated balloon. Distally, we also used a stent. We use rotational atherectomy with Jetstream. We had a great team here today. I really appreciate everybody's help. Dr. Levin and the rest of our crew was here, our anesthesiologist. Looking forward to seeing you guys in just a little bit. I'm going to jump in my helicopter, and I'll be over at the Swiss Hotel in just a little bit.
Thank you, Jaffer.
Just kidding. I'm actually getting in my car.
He's going to get in the Batmobile, I think, and come over. Okay, we're going to continue with our lectures. Next, we're going to have Prakash Krishnan talking about the LEVANT 1 and 2 trials.
Thanks so much, Eric. Well, thanks, Eric. I'd like to thank Jaffer, Dr. Murtajame, Dr. Jones, and Dr. Chamberlain, as well as all the committee for having me here, and I really appreciate being here. It's a pleasure. So my task today was really to talk about the clinical outcomes of LEVANT 1 and LEVANT 2. And I'm just going to go through this as quick as possible just to kind of highlight what you kind of need to know about these two trials. So these are my conflicts of interest. And I just want to go forward as far as the trial design, and especially LEVANT 1 is more of a proof of concept trial. And so I'm just going to go over what are the thoughts with that. So basically, it's 101 patient, 10 center, randomized to Lutonix, DCB, or PTA for SFA-Popliteal treatment. They looked at lesions like Dr. McKinsey said, not really long, but in their definition long, some CTOs, Rutherford class, popliteal lesions, but their endpoint was more of a proof of concept. They looked at late lumen loss at 6 months and freedom from TLR at 24 months, and also they looked at primary patency as a secondary endpoint at 24 months. So if you look at the protocol, it's a little different than the IDE trials here in America. It was a protocol-defined pre-dilatation, which had to be done, after which it was decided by the operator whether or not they wanted to stent or go a POBA alone route. So once that was done, then they were randomized either after stenting or ballooning to receive the Lutonix balloon angioplasty versus a PTA in a 1-to-1 randomization, or after stent to get a Lutonix PTA or a bare metal PTA. So it's a little different than what we've done here. And then, but at the end of the point, it's a proof of concept trial. So what the results showed was it validated the proof of biologic effect by establishing a reduction in late lumen loss. Whether you did a stent or whether you just did a balloon, you were able to show that this drug did work, as Dr. Vermani went over earlier. But now, and that led us to LEVANT-2 trial, which I think is the major landmark trial, and I think really has been the first drug-coated balloon approved in America. So the primary endpoints of this particular trial was composite of freedom from all-cause perioperative death and freedom from 1-year index limb amputation, reintervention, or index limb-related death. And they also had efficacy endpoints, such as obviously TLR at 1 year, patency at 1 year, and they used duplex ultrasound criteria of 2.5. So what was the study flow? So first you had to pre-dilate it with an uncoated balloon, and as Dr. McKinsey said, it naturally, took out the lesions that were undesirable to be studied. But clearly this was the study flow, and it's important to understand why the patencies with the balloon were so good, because the bad effects of the balloon angioplasty were actually eliminated from the trial. So if you had a suboptimal PTA, you just treated as per standard of care. If you had a successful pre-dilatation, you were randomized 2-to-1 into the test arm, which was with the Lutonic drug-coated balloon, versus the control arm, which is standard PTA, and then you had 12-month follow-up. Pretty reasonable trial to really look at the effect of balloon angioplasty versus drug-coated balloon angioplasty. But the interesting thing is, the Lutonix trial was also set up in a different manner than the other drug-coated balloon trials. And I just want you to keep things in perspective, because one of the major outcomes was TLR. So if you look at the effect of blinding as compared to the other two trials, and I'll go over that in the next slide, the patients in the Lutonix trial, everybody was blinded except the treating physician. So the evaluating physician, the duplex ultrasound lab, the patient, et cetera, the team, the technician, everybody was blinded throughout in order to avoid any bias regarding the outcomes of this. So basically, this is an important concept to remember, because one of the things was glaring between the two different trials was the differences in TLR. As Dr. McKinsey nicely pointed out, there was a big difference in TLR, and as we know, we as clinicians are very concerned about target lesion revascularization, and if you see, there was a big difference in TLR between the Lutonix trial versus the Medtronic trial. And so if you break this down, and if you look at the differences in the multiple DCB trials that have actually looked at TLR, you've got Thunder, which had 6-month follow-up, Medtronic SFA 1 and 2, which had 12-month follow-up, and the LEVANT 2 with the 12-month follow-up. If you look at here, the percent binary restenosis in patients with reintervention or TLR, which is I think this is my pointer, right? There's my pointer, which is the bottom right here. You can see 66% of patients who had a restenosis in the plain old balloon angioplasty arm also went for intervention. Again, 30% in the Medtronic trial, and only 0.5% in the Lutonix trial, showing that the effect of blinding to really clinically look at what is driving your target lesional revascularization. Is it clinical symptoms, or is it just a knee-jerk reflex because the patient is a bare balloon and has had a binary restenosis rate? So it begs a question on how you evaluate the data. So I think it's important to take that into consideration. Now, what about baseline characteristics? If you look at, I wouldn't consider this a real-world trial, but clearly they looked at restenosis, they looked at proximal pop, calcification, occlusions. Again, there was a bailout stenting rate around 2.5%, which is pretty low. But they also looked at diabetes and Rutherford, showing that they did look at a moderately complex group of patients for us to evaluate, what we're going to do in our practice. Now, where's the meat? Now, this is the clinical results. Well, first and foremost, I think we've all agreed now, we've used drug-coated balloons in America since last year, and you know that this is pretty much safe. Okay, it's a non-inferiority in safety as compared to balloon angioplasty, and I think that's important to remember, that you're not giving a therapy that's in any way dangerous to your patient. Number two, if you look at the patency endpoint, you had a statistically significant improvement in primary patency at 12 months, 73.5% versus 56%, about a 29.4% improvement in patency at 12 months. So lastly is TLR. So even though there was no difference in the TLR statistically between the balloon arm, which I don't have a slide for, and the DCB arm, if you look at the 89.7% TTLR rates, you can see that it's pretty much equivalent to most of the stent trials that are out there when you look at TLR, whether it's Zilver PTX, Resilient, Durability, Complete SE, Stroll, whatever it may be. Important to remember, however, you are subselecting the group of patients that you're looking at. These are the patients who have basically have undergone successful balloon angioplasty. While if you break that down into in the Zilver PTX trial, your TLR rates would be better than what's actually shown here. So it's important to always look at the data. I know it's hard to compare, but clearly it's important to look at how the trials were designed. So the drug-coated balloon also helps in the walking distance. There's obviously an improvement in walking distance and also an improvement in Rutherford class as well in the Lutonix DCB versus standalone PTA. So there was a lot of question on whether we were doing proper balloon angioplasty because of this sort of reduction or no difference in TLR. And so there was a lot of thought into putting on appropriate balloon sizing. Were we balloon sizing 1-to-1 or not? And the company actually went through this big ad hoc post hoc analysis and actually measured the balloons and found that the balloon to artery ratio was actually less than 1-to-1 in the drug-coated balloon arm. And what they did was when they found that they actually opposed the balloon in the arm, your primary patency was even more improved. So saying that as operators, we basically undersized the balloon in the drug-coated balloon arm. I mean, as a clinician, you know, I look at the way the trial was designed, and I was designed to be an eyeball evaluation of what it was, and you did that both in both arms, and we did that in all the drug-coated balloon trials. So I don't know how much weight I put into this, but I think it's important to remember that part of the biologic effect of the drug is to allow the drug to oppose the wall. So I think the take-home point from here is to make sure you size the balloon 1-to-1. I don't know whether this is true with the data as suggested by Bard, but however, I think that it is a take-home point for us to size the balloon appropriately in order to allow the biologic effect of the drug to take place, as Dr. Vermani showed earlier. Now, other secondary safety endpoints, you can see there were no differences in amputation or intervention for thrombosis, again showing out to 12 months it was good. Now, recently in SVS, I was fortunate to get some of these slides. They actually presented the 24-month data, which I think we're very interested in as interventionalists because, yes, I think we're all convinced that 12 months, this particular balloon is better than a bare balloon at 12 months. But how is it, and we know in SFA disease, 12 months is not really a long-term follow-up. You know, you want 24, 36, 5-year data, et cetera, like you have with Zilver PTX. So at 24-month, they went ahead and looked at the 24-month outcomes. And if you look at Lutonix, it demonstrated non-inferiority and trends towards superiority in terms of safety. But if you look at the patency does drop off from 74% to 58.6% at 730 days. And standard PTA also dropped off a little bit to 53%. However, you still maintained a statistically significant difference, just barely, here in terms of patency. Again, you're at a 10.5% improvement over PTA, but it starts to beg the mechanism of restenosis. I think a lot of us here have been discussing on why this happened, whether there's a need for scaffolding, whether there is recall, maybe that we're leaving too many dissections behind. And I think it shows that the science of DCBs are still evolving, and especially our ability to use DCBs to actually treat these patients needs to evolve as well. So again, your freedom from TLR, again, continued out. Again, you had a suspected drop to 82%, as you would see. But again, this also continued to look stent-like in terms of, you look at the current stent data out there at 2 years, it pretty much mimicked that. So again, you know, it's not the best results, but at the same time, I think you're starting to see that there is some late catch-up with DCBs, at least with the LEVANT 2 data, and I'm very excited to see what the Medtronic data is going to show us at 2 years. So again, the safety endpoint also continues out to 2 years, showing that this balloon remains safe and you won't have any either major amputations or late thrombosis like we had in the coronaries with the drug-coated balloon. So in conclusion, with my last 50 seconds, I think I just want to sum up with 3 things. I think our understanding of drug-coated balloon technology in the superficial femoral artery is growing. I think it's exciting to have data out to 2 years. Look forward to the Medtronic data coming out very soon, or hopefully a TCT, to really compare the two. I think it's unfair to compare trials because I think, as you saw with the trial design and with the bias and whatever it may be, it's unfair to compare trials. So you need to take each trial at its merit, and I think as a group we need to come up with our own algorithm for treating these patients. One important thing that's going to occur is an understanding of the patterns of restenosis in DCB. And it'll be exciting to see if the patterns of restenosis are changing and whether this will then let us know who we should stent concomitantly with DCB and who we should not. I thank you for your attention.
Thanks, Prakash. Next, we're going to have Jim McKenzie back up and talk about the IN.PACT data.
Thank you, and again, thanks for the invitation to come present the different data. I don't think this was meant to be a crosstown rivalry discussion here or anything, but I'll take the challenge on. Okay. Oh, there we go. No new disclosures here in the last hour and a half. The one difference when you're kind of looking at what we're looking for the IN.PACT trial, again, the Admiral balloon, it's a well-recognized balloon, been used for many years as a standard angioplasty balloon, nothing new there. Paclitaxel, a well-recognized drug that we use for the treatment of restenosis. Urea is the secret sauce, the excipient that allows the maintenance of the drug on the balloon and release as it hydrates, as it gets into apposition with the arterial wall. And then obviously the coating process, which is fairly elaborate of how they actually do this and get the drug equally coated on the balloon, then rewrap it and everything else. It looks like you're in kind of a Ebola center as you see how they do all this. It's pretty impressive. Difference of anti-myoproliferatives, I think this is something that we're still trying to figure out what is the right drug to use. Obviously in the coronaries you see more the everolimus, and then in the peripheries you're seeing more paclitaxel. Paclitaxel is cytotoxic, whereas everolimus, the rapamycin, are cytostatic. So as the drug becomes less effective, the tissues can recover and continue to proliferate, whereas it will lead to apoptosis with the paclitaxel. One thing we were talking, and Dr. Mane and we were mentioning before, some of the mechanisms of action may actually be a depot type of thing where you have crystals of paclitaxel being embedded in the arterial wall, then slowly releasing over time. So my challenge was to look at the clinical evidence for the IN.PACT trials, and so I'll be touching on the global registry, which I mentioned earlier, as well as the SFA trial for the 12-month data, and then subgroup analysis. The IN.PACT SFA trial, if you look, it was a U.S. trial for going to approval, 181 subjects enrolled in 44 sites, independent and blinded Duplex core lab, as well as an angiographic lab, and a CEC, as well as a DSMB, a data safety. So any type of event occurred, it had to be reviewed. And so if you're saying, well, was there a bias, as PK kind of alluded to, that means if someone re-intervened, there had to be a review and say why. And so I think I would differ a little bit with the concept that the decision-making and the TLR rate is related to a physician bias, because it had to go through these several different independent bias, monitoring groups before it was actually produced. External monitoring 100% of the data. The original IN.PACT trial, SFA, was a European trial, multi-center, prospective, randomized, single-blinded trial. And they're being filed for up to 5 years. Here's the design. Basically similar to what we saw, Ruther-Becker 2, 3, and 4. The same anatomic and clinical inclusion criteria as I alluded to before. They had to have a successful predilatation without significant flow-limiting dissection, and no need for a stent, and a residual stenosis less than 70%. If they met those criteria, then they're randomized 2-to-1 for the drug versus plain old balloon angioplasty, or POBA. Here you can lesion length is slightly longer in the drug arm of the randomized trial, but the rest of the demographics look very similar. You see the normal incidence of hypertension and hyperlipidemia, total occlusions in 25% in the drug arm and only 20% in the POBA arm. And so really, if anything, it's biased against the DCB when compared to the balloon angioplasty alone. Similar relationship of Ruther-Becker classification, so there wasn't a significant bias going through that. And then if you look at the procedural baseline, similar instance of predilatation with success, and then provisional stenting was a little bit more common in the angioplasty arm, but was not statistically significant. Okay, so what are the results? let's get to the facts. Again, 89.8% primary patency as adjudicated by an independent duplex core lab, one that's used by most of the studies, so it's a well-established core lab, and then 66.8% in the POPA arm alone, carried out to 360 days. And there's not a convergence, as you see the tracings are staying pretty much parallel and not converging as we saw in the other screen. And then looking at TLR, again adjudicated by a DSMB and a CEC, 2.4% for the patient with the DCB, and 20.6% in those patients that had plain old balloon angioplasty alone. So a significant return of symptoms in those patients that had POBA and a lack of return of symptoms in those patients that had DCB. Secondary outpoints is clinically driven target lesion revascularization, 2.4% versus 20.6%. All target lesion revascularization, basically 2.9% versus 20.6%. So those patients that didn't have symptoms that still got revascularized was not more common in the angioplasty room. It stayed the same, slight increase for some patients that may not have had symptoms but still got re-intervened upon that had the drug arm. And then the sustained clinical improvement was obviously 85% in the drug arm and only 69% in the POBA alone arm, which was statistically significant, with a slight statistically significant increase in ABI. Safety outcomes, basically, what we saw with the angioplasty, device-related death was 0 on both sides, target lesion amputation, 0 for both the drug and for the POBA. All-cause death was slightly higher in those patients receiving the drug, which was not related to the drug as the best found, and amputation rate was 0 on both sides, as it should be for patients with claudicative symptoms. So then if you look at a risk factor analysis and confidence intervals, basically you see those patients that their walking distance, their walking speed was all significantly improved in those groups that received the DCB compared to those patients receiving plain old balloon angioplasty alone. So the subgroup analysis looking at lesion complexity, length, and chronic total occlusion, as well as age, diabetes, and gender were then also performed. And what we saw is that basically if you came through, those patients receiving the drug did better when you look at basic all factors, Rutherford-Becker class, diabetes, age greater than 75, lesion length, with even the greatest advantage for lesion lengths greater than 10 centimeters and less than 18 centimeters. CTO, also all these factors basically showed an advantage for those patients receiving drug compared to those that got plain old balloon angioplasty alone. If you look at diabetes specifically, you can see that there was certainly a disadvantage to those patients with diabetes. As you see that those patients that got drug, they did not do as well as the non-diabetic patient population, but they did better than those patients that got plain old balloon angioplasty. So there's a slight fall off with the diabetic group in both groups, but still they did better getting drug than not getting drug. The global registry is what, again, I alluded to in my first talk of being more real-world type of experience. It's prospective outcome using the Admiral balloon again, but this time they can have single or multiple lesions as long as they're greater than 2 centimeters. All task classifications, SFA and popliteal artery could be included, or either of those, and in-stent restenosis, calcification, chronic total occlusion up to 10 centimeters were all included in the global registry. If you look at now, we're looking at much greater numbers. The plan is to have over 1,500 patients involved. They've already enrolled 1,538, so they've reached their goal, and then getting the long-term follow-up. So right now, we currently have 655 patients of the global registry that have met that 1-year follow-up period that allows us to analyze the data. This also included those patients with de novo in-stent restenosis, which meant they had no other intervention after the initial stenting. Chronic total occlusions and long lesions were all included, with over 150 patients in the long lesion cohort. So then you look at the data comparing with the IN.PACT trial. The lesion length, again, was, our lesions per patient was usually right around 1. Popliteal involvement was in about 1/3 of the patients. De novo lesions in 2/3 of the patient. In-stent restenosis in 20% of the patients. And CTO was about 35%. So again, more real-world type of distribution as you look at it. Going down to the outcomes, you look at the clinically driven target lesion revascularization for all patients in the 655 patients that were followed up was 8.7%. So again, more complicated lesions, more likely need reintervention, and with clinical symptoms. You look at the primary safety endpoint was right at 90% again, so very safe procedure. All-cause death was 3.3%. And all target lesion revascularization was 9%, and all target vessel revascularization was 9.9%. That's one thing when you're doing DCB, you need to make sure you don't leave those geographic miss areas, because if you come in and you put the balloon in there, you blow it up, and then you let it down, if you don't know, did you really cover the whole lesion? Unlike a stent, you can see, obviously, I left tissue behind or not, or untreated atheroma. So it's important that you actually mark your lesions, as we saw in the live case today. Use some type of external marker so you know that you actually are covering the whole lesion. If you, now, again, comparing between the IN.PACT SFA trial and the global registry, just to kind of bring everything together, 2.4% clinically driven target lesion revascularization at 1 year for those patients receiving drug. Global, it was 8.7. Target vessel was 4.3 versus 9.5. So you're seeing about a doubling of the area, but still single-digit type of reintervention rate. Target lesion amputation was very low, only 2 in the global registry of 655. Lesions were longer in the global registry, now a mean length of 12. And CTOs was about 35%, in-stent restenosis 20%. So the complex lesions that we're seeing on a day-by-day basis were really more impacted in the global IN.PACT registry. Here's a quick example, and this was done by Dr. Work, basically showing a patient that got one therapy on one leg and the other therapy on the other leg. You can see as baseline, they had bilateral SFA disease. They were angioplastied, where you can see on the left side of the screen there was plano balloon angioplasty. On the right side they got drug. And then at 6-month follow-up you saw significant recurrent stenosis on the left. And then on the patient's right, your screen left. And then the patient's left, your screen right, actually had significant residual or lack of restenosis on the drug-coated limb. So here you're seeing in the same patient, same environment, dramatic improvement with the drug-coated balloon compared to plano balloon angioplasty. Long lesions, long CTO lesions, again, this is something where you have to be willing to cross and use multiple balloons. I know that Lutonix has just allowed, gone up to 150 centimeters, so 150 millimeters, so we have longer balloons to use, but you can treat long CTOs with DCB. I would say that you may accept not quite as angiographically appealing picture with this, but you allow the DCB to work, and that generally will heal over time. So I think what we're seeing is the lowest 12-month TLR rate and patency, highest patency rate in the SFA trial. We're seeing with the global registry, as I've mentioned, more true real-world type of lesions being treated with a very effective and appropriate results of a 9.4% patency at 1 year. So I think we're all looking forward to more data as it comes forward, and I think this, again, as I mentioned before, is a therapy that's here to stay, and we just have to make sure we use it in the appropriate patients. Thank you very much for your attention.
Okay, I think before we go to Tom and his next lecture, we're going to go live to Tucson. Is Miguel there? Miguel, wake up.
Good morning, guys. How are you guys doing over there?
How you doing, buddy?
We're doing fantastic over here. I heard that music. I don't know what you were seeing, but it was like chariots of fire.
Yeah.
And then you go to these two
That's
Hispanics
right.
over here. It's probably a big disappointment. Anyway, great to have you guys here in our humble territory in Tucson. I'm very pleased to be here with my partner and good friend, Dr. Luis Leon. In the presence of a great team, we have Rob on the table, Cami as a nurse, and we have Ed Salazar in the back helping us as a tech. We have Dr. Favela, our anesthesiologist, helping us today, and we also have some professors invited from Ecuador that are with us. That's something frequently that we have from Latin America. So in any case, let's get, for the interest of time, let's get going. Let's go to the slide set, Chris. Chris Woolley is our director here locally, and that's the case number 1. Go next slide. This is a 72-year-old male, right lower extremity critical limb ischemia, Rutherford 5. We've been trying to move forward more with describing wounds better, involving infection, involving wound characteristics. So he has a wound 1, ischemia 3, which means profound ischemia, small wound, and a foot infection that was at the forefoot with erythema. He had a remote endovascular intervention over 5 to 10 years ago. He really doesn't remember. It was in another facility. He's now a snowbird in Tucson, and so he rolls to us with this situation. His ABI is 0.5, probably due to some also calcification, and his duplex shows in-stent occlusion. Next slide. As you can see, it's a fairly long. He has 2 self-expanding nitinol cut stents that have been placed, unfortunately, all the way up into the common femoral, going through the profunda femoris, something we personally try to avoid, and some collateral pathways that fill that above the knee distal SFA and popliteal with what seems to be 2-vessel outflow. Next. Our plan tonight is, this morning, is to recanalize the stent, try to debulk as much as we can, and then we have planned forward to relining this with PTFE covered stent, something we usually do in fairly long old CTOs of stents. So let's go to the images. Ed, if you can roll that first image. We're going to bring you to some of the work. We've been behind the scenes doing some work. This is just a diagnostic. It shows the same thing that you saw before. Look at how high that stent is riding into the common femoral, something we'll definitely have to take into consideration since we're planning on putting a PTFE covered stent. Go to the next one. We were unfortunately unable to go through that stent antegradely, as I'm sure many of you have come to when you're doing with these long in-stent occlusions. It's really hard, and the wire will tend to go outside of the stent very easily and dissect in a subadventitial fashion. So we did our first puncture of this, and this was able to cross partly, but we had to do actually 2 puncture sites to try to get that all the way up. So show the next one, Ed, please. As you can see now, we have 2 distal puncture sites, one at the mid old stent, one at the distal old stent, and then a wire that's potentially, you see the above the wire, it seems to be in the lumen, but it isn't. That's actually outside of the stent, and that's the reason why we actually did this. So show the next reel that we selected. Here's the area where you put that wire, and look at it, how it nicely traversed into the common, into the superior epigastric all the way up there. We certainly pulled that wire back and redirected it. Show the next part of it. We snared that from above, up and over. We have a 7 French up and over 55 centimeter sheath. Pulled that back, created a rail. Go to the next one. And that allowed us to go all the way down past the stents, and hopefully, what we think, we are hopeful that is an interluminal passage. Because of the way the wire behaved, we feel fairly confident about that, and we don't believe that we're going to do any IVUS, but certainly we want to debulk. Now, the choice of debulking that we selected today to demonstrate is the directional atherectomy device, the HAWK-1. This is a new iteration by Medtronic of what was the old silver and turbo Hawk, and it is their attempt in trying to make it a little bit easier, I think, on the user, because before, and I can tell you this is one of my big criticisms, it's such a pain to try to select out of like 25 different Hawks they have for the vessel. So this is their way of trying to make it more effective. The RPM came up, the cutter is more effective, and you can clean it in an easier fashion. Same thing, it's over the wire. It's a rapid exchange system, and on top of that, they did a fancy new orange button on it. Apart from that, I don't think there's anything else. I want you to focus on here on the bed. we have that hawk, and I'm sure Chris is working on it, but before we slide it in, we just wanted to show it. So that's the hawk one, like I said before. And I think one of the things that we have been we believe passionately about the fact that when you just compress the instant restenosis, what you're just doing is literally pushing the water out of the intracellular space of the intimal hyperplasia. If you would do an angio probably 30 minutes or 2 hours later, I'm sure a lot of it comes back to where it was at the beginning. So we really do believe in taking some of that out, and it will allow a much better three-dimensional apposition of the neck stent we're going to use, because when you just try to shove it in there, for those of us that have been unfortunate enough to cut one of these out surgically, it is completely occluded, so that it's really hard to try to get something to go. So as you can see, Luis is slowly moving that forward. We're going to try to come a little past that initial first centimeter of the stent and start. Now granted, let me just say this and go on the record, the company does not support in any way, shape, or form the utilization of this device for this before some of you guys flip there. We have honestly a lot of experience in utilizing it. We feel comfortable. We discuss ahead of time with a patient that we're going to be using this device off-label, but I'm sure that soon enough that will be something into consideration for the FDA to change that, because there is already European data coming out that has proven to be very good. So Luis, if you want to just start going there, and we'll start, I'd like to hear some of your ideas. I mean, it was honestly a little hard for us to get through those, and in your experiences, I'm sure we have a fantastic panel. What has been your experience in trying to deal with these complex, really old 5-10 year SFA instant occlusions?
Yeah, is that on? There we go. Miguel, great effort in crossing that. That was, I think, a good demonstration of some different access techniques and how we can usually get across these. The one question I want to ask you, are you using a filter at all with this?
Yeah, absolutely. Good point. As soon as we went all the way past this, we were able to slide an 035 diagnostic catheter down, and through that, we opted to go with a Spider 5 filter, and we felt that the apposition of that was adequate. As you see, one of the very important details technically that Luis is showing really well is the fact that the cutter never really comes in close contact to the metal struts. And if, of course, your tactile sensation is that you're hitting a strut, you want to come back and you want to redirect that wire. Again, I'll be honest, I haven't really done a lot of Hawk 1s. This is maybe our second or third case, but at least the company is saying that what we used to do with 6 passes, now we could do with 4 passes because of the RPM and the way the new cutter is shaped in a much more adequate design to have a better wall position. So again, I think I'd say jury's out on that one, and I'll tell you more as we utilize more of this device.
Miguel, it's PK. I'm just wondering what do you think the differences between the Hawk 1 and the laser are in this particular thing? I agree with your idea of debulking, but any thoughts on Turbo Tandem versus Hawk 1? Any algorithm that you could suggest?
Okay, there are, I think we definitely have to be data-driven, and if we're data-driven, we definitely have stronger data that has been recently presented by Eric regarding the good results that we have by debulking with laser atherectomy. I would tell you, for us, it's been a technical constraint, because when these operating rooms were built, they didn't foresee having a 220-volt adapter for our laser. So we have been eager to try to get this reinstalled into our room. So I can tell you, at least in our algorithm, it has to do with some of the technical constraints we have. I don't know if I would have a clinical reason for not doing that. That would support it. Do you have an algorithm? Because it's certainly interesting to know how other people go about this.
Yeah, I think, Miguel, your point is very valid, and you're not alone. There are places that simply can't fit a laser in their room, or they can't hook it up for the voltage requirements or whatever. And I've certainly done Silverhawk cases for ISR. The one thing I want to point out about the FDA is that you know, one of the things that they were very keenly concerned about was laser stent interaction before they even approved the protocol. And Spectranetics literally had to take a laser and pulse a stent about 1 billion times to make sure that the metal didn't deteriorate, melt, crack, break, or whatever else. And so there's a huge safety component that went into even designing the protocol before it even started or before it got approval. I think we've all shaved out stent struts before the Fox Hollow, and I would be surprised if that type of protocol ever got through the FDA. Not saying it couldn't, but I think that you have to be quite cautious when you use this device inside stents, because you have stent struts that don't always lay parallel, and they stick out in the lumen, and you can catch one and shave it off.
Absolutely. I can tell you, historically speaking, let's do just this one more pass, Luis, and we'll dilate that a little bit, see how it looks. Probably one of my only superior fractures has been a patient that actually underwent a series of directional atherectomy. So you can certainly make a case that there might be some stress, and that's something in the back of our minds that it would take some time to convince the FDA of it. But certainly there's, as I said before, some robust data coming from Europe that shows it. I mean, we can certainly put together our own likely. So let's do a small shot here, Lucho, see where we're at.
The other thing I wanted to point out too is that, you know, I think that particularly with the Reline trial, we're starting to now have level 1 evidence on how to approach ISR patients. And before, it's all been anecdotal. People kind of do this and they do that and they claim everything works. And so we're now beginning to formulate a treatment strategy. I think most people agree, we had this discussion in the last case, that atherectomy of some form is beneficial in ISR patients. But to me, the biggest questions now become is what happens when you debulk it and then add additional therapy like a Viabon or drug-coated balloon in combination, because none of the outcomes of any of these studies have shown 0% recurrence. They all fail in some degree. And so we haven't cured patients of their problem yet. They still come back at some point. And so I guess my biggest question to you is, what is your feeling about combination therapy?
I mean, I can tell you the data certainly is lacking, like everything potentially that we're doing. But we have, you know, at least for the algorithm today, we certainly have some of the Reline data, which has shown this at least to be a partial good solution. I think it's going to be great to have a little more data that will allow us to show in a more robust way what this is. But moreover, another thing that I feel that we have to come and put our heads together, and one of the great things about this meeting is the fact that this meeting has everybody in the game. We have IR, we have IC, we have VSS, because we don't even have a way to follow these patients. What's our algorithm to follow them? What's our surveillance pattern? When should we intervene in these patients? Should we intervene when they're getting to high velocities? And I can tell you, we found in our own retrospective analysis that patients that have asymptomatic but high degree in-stent restenosis of 80% or above, let's do the proximal part loose, they have major adverse limb events associated to this. So a lot of more conservative surgeons and operators will not deal with this. If the patient's not feeling anything, they won't touch him. We tend to be a little more aggressive. If that stent's going down and you have 80, 90% in-stent restenosis, like I said, major adverse limb events, major amputation above the ankle and knee amputation, so on and so forth. So it makes sense that that we're having these conversations, and I think Jaffer just hit it right on the head with this, the dawn of ISR, because I don't know, Luis, what do you think? About 50% probably of what we do nowadays is just re-intervening on what we did at some point in the past.
I agree.
You know, and I think one of the problems is that we all want to make everyone be 18 with normal vessels and everything else. And we've got a foreign body left behind, and we have patients that have a predisposition for forming, you know, atherosclerosis and animal hyperplasia, whether it be because of dietary or genetics or a combination of all the above, and smoking. So, I mean, I think we're not going to be able to cure this disease process. It is an annuity. They do come back, and we have to try and get as much as we can with the technology we have. And I think that's really where the problem is going to be is, what do you do where, and whether it be debulking, and I think we're having more, I think getting more data is going to be very helpful, but I think it's still going to be these patients will come back.
Jim, in light of all that, particularly as a surgeon,
You want to do a shot there?
where in the algorithm does conventional surgery with a FemPop bypass utilizing autologous vein as a conduit fall
Right.
into the algorithm?
Paul, I think that's a great question, and this is a great venue for doing it, where we have everyone talking together and working well together. My algorithm is basically I am endovascular first, and it depends. Now, if I've got somebody that comes in that has significant gangrene of their foot and a good vein, I would consider putting a bypass in first to get, if they got, needing a long segment CTO treatment and everything else. Someone coming in with claudicative symptoms, things like that, exercise program, smoking cessation, making sure they're on statins, seeing their cardiologist and everything. Then I'll come back in and I'll try an endovascular procedure. If they fail, or if it looks like they have the whole long calcium artery that I know is not going to do well, and they have a good vein, I'll come in and I'll do a vein bypass. If I come in and they don't have good vein, or they're not just a hunk of calcium going down, I'll try an endovascular procedure. If they recur, I'll re-intervene on it, but then I'll start talking about, well, we may need to do a bypass. The second time I have to re-intervene on it, then I'm going to really recommend they have a bypass if they have good conduit. If they don't have good conduit and I have to use synthetic graft, I will probably try endovascular again if it's a short focal lesion.
So good conduit, 3 failures at endovascular therapy, then surgery?
Well, at least the first failure, and then go back and then re-intervene. So it'll be the primary procedure and then a re-intervention. If they recur again, then I'm going to be really pushing for a bypass.
That's very
And
nice.
I think the point here is that we must not forget that surgery still has a role here in our algorithm. And I think all of us agree endovascular is first, but let's not forget about conventional surgery.
And one other point that I always want, especially when you're putting stents in, you have to think, well, if you can't do it, if someone has to come in and do a bypass, are you burning an above-knee popliteal landing zone by putting a stent there?
Absolutely. I think that's a great point.
As a surgeon and an interventionalist, I have to get schizophrenic and talk to myself of saying, well, if I put a stent there, am I burning a bridge? As IR and IC, they should, either have a collaboration, or it's fairly simple. You can say, well, is this going to burn a bridge? If it is, don't do it.
Well, I think you have to look at several factors in making that decision about surgery. To me, in my practice, I look at the extent of the restenosis process, number one, and I look at the time interval between successive procedures. I think the key is to look for, more focal restenosis with broadening intervals between successive procedures. And I think the key each time is to try something different. Incorporate new technologies to try to give a greater degree of durability. Don't keep doing the same thing. Don't just keep dilating it, but try different technologies that could translate into a more durable long-term result.
Good
Yeah,
point.
I think the other point to keep in mind is the same way that Miguel doesn't have a 220-volt outlet, you need to have a vascular surgeon that's reasonable that will operate, and I don't have that in my facility. So I would do endovascular therapy on this repeatedly if they need it, because that's just what I have available.
I still have new patient visits available.
I'll send you some. I will put them on an airplane and send them to you.
It's not actually
Well, Miguel, I know that you're going to use a covered stent here, but I just want to point out that the single-center Japanese data with Zilver PTX, is very impressive with the ISR end of it. It's real-world patients, and you have 2-year follow-up with that. So I think if here I know that the profunda is an issue, and maybe distally you can use a covered stent and maybe proximally a Zilver. Adding cost, I understand that, but clearly I think that I just want to point out that there are other drug-coated stent technologies, although it's not randomized level 1 evidence. Clearly, you do have some registry data that's showing with large number of patients and good follow-up that also seems to work.
I want to put a little piece there. So let's just do this distally then, a little bit more distal this one, and then we'll do a short one there. Yeah, no, all good points. And definitely, I mean, we're surgeons here, and we love operating. A little bit, let me just push that there. There you go. So this particular guy was victim to the vein clinics throughout America, has bilateral GSV RFA ablations, which they thought was the reason why he was having all these symptoms in his legs. And honestly, it ended up being all arterial in nature. So we didn't really have a good conduit, and that was maybe the main reason, but we would have no problem in cutting down doing a nice bypass with vein, which makes a lot of sense in a lot of these patients that have chronic disease with these long-term big metal implants. Another thing we're figuring out here as we do really, really oblique images is that stent actually wasn't that bad. It's not really writing that much into the profunda as I thought it would. Can I have that 6 balloon here? So I want to pre-dilate that proximal edge a little bit more. And we just deployed a Biobond graft at 6 by 25. By the way, they're telling me that we have 5 minutes, so maybe if you guys just give me 5 more, we should be able to get here with a final shot. Rob, chop, chop, chop.
Miguel, what do you think about a drug-coated balloon there before you do any other therapy? I mean, even if you put a stent there or do more, I just, to me, it makes intuitive sense to dilate that with a drug-coated balloon right there. Even if you do need to put an additional
You know what?
stent.
That you bring up a really good point, and I would love if you guys gave me an answer to that dilemma. But do you believe that the DCB will actually create or incite necroses and apoptoses of the cells that are already there? Yes. Or is it really just halting the reproductive cell cycle, which means it will minimize the amount of new intimal growth?
Well, we have Dr. Vermani here who probably knows more than anybody in the world, so she's going to answer that for you.
I'd love that answer, because if not, it wouldn't make sense to use it just to treat a bulk of material without debulking it first.
I think drug-coated balloon is a good idea here because it will affect your plaque itself, because that's how it really works. Why does it prevent the proliferation? The cells that are there, not everyone is going to proliferate. Some of them are going to die, and that is going to come from the drug itself. That's why paclitaxel works more likely as compared to the cytostatic drugs, which actually don't work in the peripheral artery very well. You've seen all the stents that did not work. So I think paclitaxel is the better way to go in the peripheral, because you can kill
answer
those
me
cells.
then another question I have regarding this is, do you believe that then these cells that are in this intimal fibrotic tissue are active cells that are still reproductive, and that they're just going to have a cell cycle that eventually will lead to cell death and all of it will disappear? Or is it a fibrotic tissue that it's there to stay forever to a certain extent?
It actually depends on the type of how long the duration of the occlusion is, how long was the restenosis. If you look at the number of cells that are there beyond 18 months, the smooth muscle cell numbers will decrease over time, just purely from the fact that they're producing a lot of collagen and they don't get the nutrition they need to get. So it depends on the duration. If it is less than 18 months, I tell you, you can make a difference. You know, if you got a long-standing restenotic lesion or total occlusion long-standing, you're in trouble because there are not that many cells there. So
yeah, that's the thing. And this guy has these stents placed 7 years ago. So I don't know, and I don't believe that will be the solution completely, but it's a great conversation point, and let's just see where we're at. So you see still that fibrotic lateral edge there. The whole thing looks beautiful. Luis, if you could just show us that runoff there. Let's look at it distally, and we'll probably behind the scenes just do a little more debulking on that lateral wall, and then show you, then we can just show you a final result when we come back. We have 3 back-to-back cases today to share with you guys. Let's just see how it looks here.
So Miguel, why don't we break here and come back, and we're going to do one more quick talk here, if that's okay. And then you can
3
show us the final.
seconds. 3, 2, 1. Okay, now you can.
Perfect. All right.
Stay tuned.
Our next lecturer is a good friend and mentor, Tom Shimshak. He's going to talk about does stent design, radial force, and oversizing affect patency?
Thanks, Eric. Thank you, Eric, and thank you to Dr. Golzar and the Planning Committee for the opportunity to participate in the meeting. So as Eric said, the topic of my presentation is does stent design, radial force, and oversizing affect stent patency? These are my disclosures. I'm going to answer the question by discussing some basic stent performance concepts and then deal with some clinical data. We all know that the SFA and popliteal is a very challenging vascular bed. It's unique in terms of the pressures and the forces that it's subjected to, shortening, twisting, compression, bending, to varying extent depending upon where in the SFA we are. Particularly at risk is at the distal portion of the SFA where bending and kinking forces are most dramatic, and that impacts stent performance. But throughout the vascular bed, there are varying forces that are at play. Standard nitinol stents, which we've enjoyed for the last 15 to 20 years, were originally designed to optimize acute results, but more importantly, to confer durability. These stents are cut from laser tubes, and by design, they were deployment strategies that incorporated oversizing, 10 to 20%. The goal is to assure apposition of the stent against the vessel wall, and through that apposition, confer a continuous chronic outward force. These factors, however, have translated to suboptimal long-term results. Compression resistance is a factor, limited stent flexibility, particularly for very stiff stent designs, kinking and fractures, which impact long-term patency, and overall affect durability. This is a historic perspective looking at stent platforms in a variety of trials, and I think it's safe to say that for all stent platforms, traditional standard stent platforms in the SFA, whether it's bare stents, drug-eluting stents, or covered stents, the shorter the lesion and the lesion length that's being treated, the better the stents perform. All stent platforms start to fail the longer the length of the disease that we're treating. There are two important concepts in terms of standard nitinol stents that you need to understand. The chronic outward force that these stents impart by virtue of their design and by virtue of oversizing. That oversizing leads to a continuous chronic outward force. There is data now that suggests that continued outward force, especially if it's excessive, does lead to injury, which translates to higher restenosis rates. This is animal data looking at varying degrees of oversizing. On the left, 1 to 1, 1.3 to 1, where there is some degree of restenotic process, but at the extreme, where the stent is oversized up to 2, there's tremendous tissue response and restenosis is initiated. The other factor is compression resistance. That is a very different concept. That's the outer force that's conferred on the stent that leads to crush, which can also lead to stent failure. This is an OCT and corresponding IVUS image with the corresponding angiogram on the far right, looking at the effect of stent compression. And you can see the difference in terms of the elongated appearance by IVUS and the eccentric residual lesion in terms of the angiogram. So even though you may achieve an increase in luminal cross-sectional area, ideally that's not the kind of stent configuration or final angiogram that you would like to end up with. So it's the interplay of these forces. Oversizing leads to chronic outward force. Chronic outward force, when it's excessive, can lead to excessive cellular response and restenosis. And there's this disconnect between chronic outward force and compression resistance. We have to strive for the balance that meets both endpoints. So ideally, a new stent platform should address each of these limitations of standard stent design. No chronic outward force or minimal chronic outward force, a stent that has compression resistance, yet still is flexible to overcome the anatomic challenges of the SFA. So the newer generation nitinol stent is the Supera stent, which is fundamentally different in terms of design. It's a helical interwoven design as opposed to a laser cut design. There's no oversizing. It's a 1-to-1 sizing. It has low chronic outward force, high compression resistance, increased flexibility, and to date, very low fracture rates. This is a comparison of several standard Nitinol stents versus the Supera stent on the far right, looking at the differences in chronic radial outward force, dramatic differences with the Supera stent. And this is the difference in terms of algorithm and recommendations in terms of sizing. The Supera stent has no oversizing. What's important is vessel preparation by adequate pre-dilatation and then appropriate one-to-one sizing as opposed to oversizing with the standard Nitinol stents. This is data, bench data looking at the compressive effects of outward force and the compression resistance of the Supera stent compared to standard Nitinol stents. You can see dramatic differences in the compression resistance of the Supera interwoven stent compared to standard laser cut stents. And this is that same IVUS image as I showed earlier on the left versus the typical IVUS image that you see with the Supera stent, a concentric, a symmetrically deployed stent, which is a reflection of the stent behavior itself. There's also differences in kink potential between the interwoven platform versus the standard laser cut stents as shown on the left. Minimal kinking is observed with the Supera stent. So what is the trial data? What is the clinical data looking at this? This is data from the SUPERB trial, 264 subjects. This was a prospective, non-randomized study, stenotic, restenotic, and non-stented segments or chronic total occlusions. The 73% were judged to have moderate to severe calcification, intermediate length disease, 78 millimeters, and over 85% had mid-distal SFA disease treated. The one-year patency rates were 86.3%, 0 fracture rates were observed, and the two-year durability was equally good with 84% freedom from TLR. If you look at lesion length and patency and the correlation between the two, the stent performed well for short, intermediate, and long lesions. And you will note that about a third of the patients had lesion lengths of 126 millimeters, so real-world SFA disease. Yet the patency rate at 12 months remained quite high, 87%. But what is different about this device is how the device is deployed. If you look at the far left, nominal deployment had patency rates of 90%. On the far extreme are those patients that had excessive elongation at the time of deployment, defined as more than 40% elongation. The stent begins to fail in terms of durability, the less optimally the stent is deployed. This is TLR data, nominal, and again, for varying degrees of elongation. If you deploy the stent appropriately at 1 and 2 years, the freedom from TLR is quite high, 97, 96%, and at 3 years it continues to be high, 94%. But if you elongate the stent at the time of deployment, the TLR rates begin to be affected. To date, there's been very little fracture rates observed with the stent. 12 months and 24 months analysis in the SUPERB trial showed exceedingly low fracture rates, and as you know, historically, that has been associated with restenosis. So in terms of a case illustration, this is my current algorithm for complex SFA disease. This is a patient that I treated just last week, an elderly woman with very severe claudication. As you can see, a very long CTO, beginning very proximal in the SFA, close to the origin, with reconstitution via collaterals at the popliteal, which was also diseased. This was recanalized using basic angioplasty technique, pre-dilated, distal protection deployed, and debulked with the Jetstream device, and then intravascular ultrasound-guided stenting with Supera stents in the majority of the SFA and the very proximal portion with a more precise positioning stent, the Everflex. And this is the final angiogram beginning proximally. We did treat the profunda origin, but I don't show that. This is the proximal mid-distal segments and into the proximal mid-portion of the popliteal artery. So to summarize, Nitinol stents vary in design and performance. Standard laser-cut tubular stents are associated with increased chronic outward force and low compression resistance. Excessive oversizing of standard Nitinol stents may lead to injury and higher restenosis rates. Newer generation helical stents, like the Supera stent, have favorable design features which to date have been associated with lower chronic outward force, high compression resistance, and reduced fracture potential. These features have resulted in improved early and long-term performance and lower restenosis rates. The long-term patency of the Supera stent is related to stent size, vessel preparation, appropriate deployment technique, and minimizing stent elongation. Thank you for your attention.
Thanks, Tom. That was a great talk. We're going to move quickly on in the interest of time to our next session of anti-restenosis therapy, and we're going to have Dr. Amir Mutarjameh and change our panelists here. Dr. Amir will moderate the remaining session here.
Okay, the next session starts, I believe I have a talk to give, huh? Yeah, I'm going to talk to you about the use of covered stents for in-stent restenosis. You know, there's, I don't know what's going to happen from this point on with balloon-coated with drug-coated balloons, but we have been using stents more and more, and if you look at the this curve, you see that from 2009 to 2014, we keep going up and using more stents. Stents really 64%, 64% of all the stents being used is used in iliac arteries, more than double of what we use in SFA-Popliteal, and very small percentage of that is being used below the knee. There are 10 stent trials, and if you look at them, they all have a high rate of in-stent restenosis. If we take the Viper and Vibrant stent trial out, which are not stents, they are really graft, we take those out, and then you see that in-stent restenosis happen anywhere from 20 to 48% in first year, and you jump to the third year, it's going to be as high as 81%. So that's a very big problem with one of the devices that we use very often. You don't see any lab that any day you walk in, they don't use stent in some patients. So what are the options, treatment option for in-stent restenosis? A balloon angioplasty of different type of the balloons, or good old balloon or cutting balloon, cryoplasty, now drug-eluting balloon. It's very interesting for the next 2 years to see where we're going to go with this drug-coated balloon. Laser, you heard a lot about laser atherectomy for in-stent restenosis. Restenting, a lot of people put a second stent inside the first stent. And atherectomy, of course, very nice debulking device. Now we're looking at the covered stent graft for in-stent restenosis. We looked at our stent restenosis, look at 600 patients, 176 of them had restenosis for 30% rate, and we treated a bunch of them with just balloon angioplasty and a bunch of them with atherectomy and angioplasty. And the result was atherectomy and angioplasty had a double patency rate. In other words, was much superior to the balloon angioplasty alone, but still had about the 28-month was the best of the patency rate, a median of 12.3% patency in 1 year. Now, there are 3 randomized, multi-center, prospective clinical trial for in-stent restenosis. One is the recent one, RELINE, which is using a Viabon stent graft. The second one was Exemer ISR. And the third is FAIR trial, that is balloon-coated, drug-coated balloons. Now, if you look at the patency rate of these, or look at the number first, they use 82 patients in FAIR trial, 196 for Exemer, and RELINE was 173. Their patency was 70% for FAIR trial. That is drug-coated balloon, but the lesion was not greater than 10 centimeters. The average was 8.3 centimeters. And Exemer laser was only 40%, but RELINE study, which is putting the Viabon stent graft inside the stent, was 75%, was higher than even drug-coated balloon, but the lesions was considerably longer. We did 42 of these patients treated with cover stents, and 33% of them were for stenosis, and 67% of them were for total occlusion, and 64% of them had atherectomy before balloon dilatation and stenting with Viabon stent graft. This is our protocol. Cross the lesion, debulk them with a excisional atherectomy, then we do a balloon angioplasty, then we treat the patient as de novo. Once you get past doing an atherectomy and angioplasty inside the stent, then you have to treat the patient as de novo lesion. It doesn't matter, is it above the stent, below the stent, you have to treat the patient from diseased to diseased area. This is an example of cases that we have treated. This is the limb salvage case in a 67-year-old diabetic female with a long history of CLI, multiple interventions, multiple amputation of the toes. I saw this lady back in 2003, and up to 2008, I did 14 procedures on her, only the left leg. I treated both legs. And she was keep coming back with occlusion, restenosis, and this is just a couple times before we use Viabon on her. As you see, diffuse stenosis throughout SFA and stented area. She had an atherectomy from top to bottom. And these are the amount of the plaques removed from that artery. And very nice angiographic result. But unfortunately, this patient came back 3 months later with that picture, totally occluded top to bottom. We did a lytic therapy on it because it was a recent occlusion, definitely had clots. Then we Viabon from the top to the bottom areas that was diseased. 9 months later, I went back to do angioplasty of the anterior tibial artery because she had ischemic ulcer, was not healing. These are the viable 9 months later. And this patient, look at the runoff, the lousy runoff. And I sat in front of this picture, look at them for a long time to see why this viabon is patent. It really shouldn't be patent. Then I realized that this patient has no competitive flow. So as long as she doesn't have competitive flow, the viabon is going to stay open. And this went on. This ultrasound that you see here was taken in December 2012, 4 years after treatment. And as I'm talking to you today, which is now 7 years after I put that viabon in, still is patent. Now for patient with claudication, this patient was treated. It was a 65-year-old gentleman complaining of claudication, was treated in '05. And this is atherectomy, post-atherectomy, angioplasty. If you look at the result, it looks very nice. But unfortunately, this patient came back 6 weeks later with reocclusion. As Dr. Shimshak said, so you do something different each time the patient comes back. So this time we put a stent in him. Went back and 5 months later came back, occluded. That's 2006. We went out, did the lytic therapy, atherectomy, angioplasty, then we put a viabon in him. And this ultrasound was taken 2 weeks ago. That is 9 years after I put a viabon in. And as you see, the viabon is totally patent, and that's her. In conclusion, treatment of in-stent restenosis with cover stent, of course, it gives you much longer patency rate than any other device so far to this point, but we have tried. That doesn't mean that every viabon stent graft is going to stay open. Like, no, some of them that we put in for limb salvage, they occlude within maybe 6 months. But if you treat them right, they stay patent for a long time. Thank you.
Back to live cases, and it's my pleasure to introduce our next speaker, Dr. Carlos Mena, who will discuss 5-year results of drug-eluting stents in the SFA. Welcome, Carlos.
Good afternoon. Thank you very much to Dr. Goldstra and the CVC conference for having me. I'm given the task to review the data from one of the few devices that we have available in the U.S. that will deliver medication into the vessel wall. Certainly the drug-coated balloons have been discussed in light on the recent publication in New England Journal of Medicine. This is my conflict of interest. I'm a consultant for Bar, Medtronic, and Cook. The prior speaker has alluded a little bit about the issues related to the different devices and options that we have for the treatment of peripheral vascular disease. Clearly, endovascular, whether you look at it in the US or outside the US, continues to be and will continue to be one of the most predominant ways to treat patients with peripheral vascular disease. I still notice that a surgical approach, meaning open, will continue to be relevant as well. Medical therapy and exercise do have a role in this. As a consequence of all this different technology that is being developed and introduced around the world, clearly the expense and the cost of delivering therapy is becoming an issue as well. And it's important that we realize this, particularly as we talk devices that have different limitations in terms of diameters and lens sizes when you're applying or using them. This is what has been projected in terms of using a peripheral angioplasty, an atherectomy, or a stenting, and or even bypasses, what's going to happen in the years to come here in the US. Clearly, the stents have a role, and depending when you look at it, whether it's the iliac, the SFA, the popliteal, or below the knee, the usage of all these different devices is different. Some will have a more predominant role in the iliac, for instance, stenting, versus what you will see in the SFA, which will be probably divided between stenting and angioplasty. Clearly, with the use and approval of the drug-coated balloons, this may change. This is a few years old, but this is the reflection of what was being used at the time in terms of bare metal stent, drug-eluting stent, cover stents, and bioabsorbable stents. Certainly, bare metal stent dominated, and this was prior to the widespread of silver PTX and others. But unfortunately, as the bare metal stents were used and being applied to treat patients with peripheral vascular disease, one of the most vexing problems was restenosis. And here is the biological history behind it. The bottom line is that every time that we injure a vessel, whether it's just a plain balloon angioplasty or we actually deploy on the scaffold, we are going to create a significant problem. And the question is how we fight this. Well, certainly with bare metal stents, one of the issues that we'll encounter is that in general, during the first 12 months after placement, is the highest incidence of restenosis. A little bit different from what we see in the coronary, certainly, for those of you that are cardiologists. So the principle or the idea behind all these new devices is to minimize the negative vessel remodeling and proliferative effects from the metallic scaffold that is being used, and then doing so by the addition of biological agent, most of which you have seen is paclitaxel. That in an effort to prolong patency and minimize reinterventions and hopefully improve the patient's clinical outcomes. Paclitaxel has been discussed by other speakers this morning, and these are some of the features that makes it so unique and successful as being the main therapy currently to treat patients with peripheral vascular disease. There are the hydrophobic components, hydrophilic components, and the anti-proliferative effects of it. When you look at it from the biological point of view, Dr. Mackenzie alluded to this earlier, so I'm not going to spend too much time to it as to what's the ultimate pathway that will result in clinical effect. When you look at stent-based drug elution, we can think about it for the peripheral in two ways, above the knee and below the knee. Above the knee in the United States, we have silver PTX. I highlighted some of the main issues with it, including the sizes as well. Has a CE mark for Europe and an FDA approval. The next in line, probably in the United States, is going to be the Luvia device by Boston Scientific. There's a big difference between the two devices, whereas silver PTX is polymer-free, the Luvia isn't, and I will discuss in a little bit what the differences are going to be. Below the knee, we tend to use drug-eluting stents, which are used in the coronaries. We're predominantly designed for that, and the limitations with that are several, including length of the devices, the flexibility of the devices, et cetera, et cetera. But you notice in my prior slide that below the knee, we tend to use more angioplasty than stenting, and that is one of the reasons, are the limitations of stents that are not primarily designed for that. This is one of the issues related with the impact of polymer versus not polymer. Silver doesn't, Alluvia does, and in the red is silver, and the blue is Alluvia, and the main difference is how the medication is being released into the tissue, which ultimately will impact, potentially or not, the long-term effect of the device that is being used. As I alluded before, silver is the first FDA-approved drug-eluting stent in the US, flexible, self-expandable Nitinol stent, and is polymer-free paclitaxel coating at 3 micrograms per millimeter square. That's the dose density of the specific device. Drug elution versus polymer, there are pros and cons about each one of them. The polymer is the biocompatibility, the durability, and the thrombogenicity of it can potentially make it an issue. This is how the medication is being released into the tissue after it's being applied specifically for those that are polymer-free, i.e. silver PTX. The polymers obviously are going to control the way the medication is being released and will have the issues that I mentioned before. This is the clinical data, 5-year data from silver PTX, and it's an important thing to review and understand as we have more and more tools that can treat patients with peripheral vascular disease. This is the design of the study. Initially, there is enrollment, at which time patients were randomized into 2 arms, which is silver PTX versus plain balloon angioplasty. And at that time, either our angioplasty was optimal or suboptimal, defined by the presence of absence of flow-limiting dissection and/or gradings across the lesions. In those that were suboptimal, then there was a secondary randomization at what time the patient was going to get a provisional bare metal stent and or provisional silver PTX stent. These are the demographics of the patients included in the trial. In one line is the PTA and the other one is the silver. The main issues here, just to highlight, is features such as diabetes are the same in terms of no statistical difference, as well as smoking, which is things that will become or not relevant as we talk about drug-coated or drug-eluting balloons and stents. And all of it is coming from coronary data when we revascularize all these patients, and we knew that one of the most important predictors of restenosis was diabetes. So it's important to take that into consideration as we look at the results. The baseline characteristics of the patients, you can see that from the statistical point of view, there were no major differences. The only main ones were related to calcification. As you can imagine, those that are severely calcified were less likely to be a standalone angioplasty and more likely to require a scaffold. In terms of safety, I think for this specific device, like many others that have been discussed, is definitely not an issue. And the study, as you can see here, over 5 years, had a very low event rate. So safety, I don't think is a major issue. One of the things that becomes an issue sometimes that we discuss as we present data related to stents is the stent fracture, and you can see the number of events in that location. Now, the results. This is basically what you want to see, what people are interested in, will help us to understand what the role of this device is going to be going forward, specifically with drug-coated balloons and other devices. You can see that at 5 years, the freedom from TLR, silver versus optimal plain balloon angioplasty plus bare metal stent. So you got to follow the graphic. So this will be my pointer. Silver PTX. In this red one, I'm combining the data from the primary and secondary randomization. And in this other one, in the black one, I'm combining the data from the optimal PTA plus the bare metal stent, which is pretty much standard of care before the silver PTX and the other drug-eluting devices were introduced. So the difference basically will show that it's about a 48% reduction in reintervention compared with a standard of care alone. Patency, which clearly is different to TLR for all of you, I'm sure that you're aware of the difference, showed that there is a 41% reduction in restenosis compared with standard of care. Again, follow the graphic that I just showed you. So 66 versus 43%. And then one of the interesting things is what happens with patency over time. That is that in these curves, they continue to diverge. And you can see that at 5 years, there is still a 35% increase in the separation of these graphs, showing still that the effect of the drug-coated device that is being used, silver PTX, is persistent over time, and when it's compared with the other therapy or arm of therapy, it continues to be better. The clinical benefit index, which is basically the combination of clinical outcomes, including claudication, rest pain, ulcer, and/or any other form of tissue loss, you see that it's significantly different, favoring silver PTX, 79% compared to 59%. All of it is statistically significant. The other interesting part that was looked at is the provisional silver PTX versus the bare metal stent arm alone. So meaning the ones that after receive a plain balloon angioplasty, which was suboptimal, and you decided to randomize into stenting versus bare metal stent, you can see that there is a 47% reduction in the reintervention rate of silver PTX compared to the bare metal stent. The primary patency also is significantly different between the two devices, with a 41% reduction in the restenosis compared to bare metal stent. And then the clinical benefit index, which I described before, is also significantly better, favoring silver PTX, 81 versus 63%. So in conclusion, I think it's fair to say that as the first randomized control SFA device trial with 5-year follow-up, these results will highlight the silver PTX stent provide important insights regarding long-term outcomes for endovascular therapy. I think that it has been said over and over again by prior speakers how the other devices will have to meet this mark of this standard to be able to know exactly what the role is going to be in the therapy and management of patients with peripheral vascular disease. The 5-year data for this specific device versus the standard of care, which was angioplasty and bare metal stent as it was practiced for many, many, many years, showed that there is a greater than 40% reduction in the reintervention rate and restenosis. There is superior clinical benefit as shown by the outcomes that I described, and these benefits increase with time. So it's not that they stop at 12 months or 24 months, but it seems like after 5 years, you continue to see improved benefit in these patients. The 5-year results confirm the long-term superiority of silver PTX versus bare metal stent. And this is an interesting table to start thinking about where we started and where we are in terms of the endovascular therapy for SFA. We started in an era where we only have plain balloon angioplasty, and the results were not necessarily that great when you look at primary patency. Now we are in an era where we have devices such as silver, where patency rates significantly high, but they are not quite perfect. So we've made a lot of progress. We still have a lot of room for improvement, but I think that we clearly are in our way to have better outcomes for our patients. In conclusion, SFA lesions are common and complex. In stent restenosis is one of the main issues that we face, difficult to treat. The data on drug-eluting stents suggests that it is the best endovascular option potentially available for the SFA due to technical success and increased patency rates out to 5 years. The standard of care should be immediately delivering the most superior therapy at any given time. Thank you very much.
Our last speaker for this morning's session is Dr. Samir Gurmanwala, who will discuss results from the definitive AR directional atherectomy with drug-eluting balloon.
Thanks to Dr. Golzar and Amir and everyone in the planning committee for having me here. So we're going to talk about directional atherectomy and drug-coated balloon, and I do realize I'm the last person between you and lunch. My disclosures are listed for you up there. As we know about drug-coated balloons, there are several benefits. We've talked about that quite a bit here. I think one of the biggest things is not leaving anything behind, continue to maintain the vessel integrity, and having that ability to come back and re-intervene on that vessel or that lesion later on with having changed the morphology of that vessel forever. Limitations are obviously recoil dissections. We've looked at some of the data. I think Dr. Krishnan and Dr. McKenzie showed some data between LEVANT and IN.PACT, but you can see definitely the 12-month patency is continuing to do better and better, and these are great patency rates at 1 year and certainly rival that of stents, again, without leaving anything behind. The 24-month data, of course, for the US-based IN.PACT trial will be very exciting to see. One of the concerns is obviously stents. Stenting is still a problem with DCB. You can see that some of the trials, the stent rates have been up to 20%. Flow-limiting dissections as well, about 15-20% as well in those arms. And those are both concerns. One of the biggest problems that we talked about earlier, I heard not only from an angiographic standpoint, but also from a pathological standpoint, which was interesting, is that calcium can continue to represent a huge challenge for drug-coated balloons. As you can see in the cartoon, it shows you a fully inflated balloon with a big rock pile that's just adjacent. As you continue to inflate that balloon, what's going to happen? You're going to probably cause excessive injury in the lateral part of the balloon when you wanted to treat the medial part of the balloon. And so this can cause dissections, and these can certainly lead to poor outcomes. This is a nice table from Finelli, which actually looks at arc calcium. And so if you look at the amount of calcium that you have present within the vessel, between 0 and 90 degrees, you can see your patency rates out at 12 months are nearing, perfect. Your late loss lumen in the orange bar is low. And if that continues between 180 degrees of calcium and even up to about 270, as you're going around involving that fourth quadrant on the vessel and you're starting to get significant calcification, you can see that your patency rates drop off and your late lumen loss goes up. So there's a real problem with circumferential calcification. And what do we do for this? Do we balloon it, stent it, laser it, do surgery? That's a real concern that we have here. One thing that we do know is from multiple other trials that we've looked at, and if you look at a plot of this, of course we've seen from all the other trials that it's directly proportional. Long lesions are definitely associated with decreased patency and inversely proportional. So another issue is how do you treat long lesions? So I think the calcified vessels and the long lesions are the big nemesis. So based on that, there was some thought using a combination of two different modalities. One would be doing directional atherectomy and finishing with anti-restenotic therapy. And the thought was about this was, first of all, mechanically removing a lot of the plaque burden. As we've talked about, we need to have the drug delivered locally, so if you have a lot of plaque in the way, this is a way that we could remove the diffusion barrier between the actual plaque and getting the drug into the wall of the artery. So the thought was to go ahead and try to provide this sort of combination therapy. Now, if you look at trials between just definitive and just directional atherectomy, the bailout stent rate is low. It's 4% roughly. The flow-limiting dissection rate's about 1%, and the maximal luminal gain you see typically post-directional atherectomy, as opposed to just POBA, is pretty high. And I'll show you that in the DEF-AR data. Again, in definitive LE, which was a very large trial, our bailout stent rate was 3%, and our dissection that were flow limiting was about 2%. And again, the luminal diameter gain that you get post directional atherectomy was pretty significant. So if you look at some of the first DART data that was published by Chopra, this was 30 patients, Rutherford 3 all the way through 6. These were patients that had heavily densely calcified vessels, greater than at least a centimeter in the vessel. And again, this was a very early trial. But all these procedures did include distal protection, being very careful trying to achieve that number of 30% or less, which we'll talk about again in DEF-AR. It's important to try to get really good results with your atherectomy, not just do 1 or 2 passes. This was IVUS guided, so it really was able to help make sure that you did a good job with your atherectomy results. There were really no adverse effects in this 30-person trial. Bailout stenting was 2, which equated to 6.5%. Your primary patency via duplex with similar SVRs that we talk about, it was 90%. Freedom from major adverse events was 87%. So, we concluded based on this that, using DA and DCB might be a good thought, maybe a hypothesis to try to do something a little bit larger. So the current situation is still that DCBs are good. There are still problems and concerns, as we talked about earlier today, and we even saw clinical applications of this. The problem is long lesions. The problem is calcified vessels. So the thought is that was still an unmet area and a clinical need that we needed to answer the question about. So there were objectives that came out about doing a first ever randomized pilot study. And again, this is a small pilot study. It is hypothesis driven. It is to identify if this is something that's important. A study size was chosen based on a lot of other trials that were done in a similar situation. The national PI was Professor Zeller and Gunnar Tepe. This was ultrasound mediated with a core lab by Michael Jaff, and it was core mediated as well for its angiography. There was 10 sites. These are all listed for you there. These are all European. There's 121 subjects that were then enrolled in the 10 investigational sites, and the primary outcome was target lesion percent stenosis at 1 year, and that was defined as the narrowest point of the target lesion divided by the native vessel diameter at that location, and this was all core mediated. Clinical follow-up was also assessed at 30 days, 6 months, and a year post-procedure. So the design was general and angiographic criteria were assessed. It was first decided, is this lesion severely calcified or not? If it was not, it was then randomized 1-to-1 into directional atherectomy with DCB versus just DCB. And then the remaining subset, which turned out to be 19 patients that were severely calcified, were followed with, they did receive DART therapy, but were followed in another arm. So the inclusion criteria were lesions that were 7 to 15 centimeters. So again, trying to get a little longer compared to some of the other data that's available. The lesional diameters were between 4 and 7, and again, that's because of the size of the drug-coated balloon. The exclusion criteria was in-stent restenosis, aneurysm, or if there were multiple lesions that required treatment in that target limb. And the devices that were chosen in this trial was the Silverhawk or TurboHawk plaque excision system, and at that time it was the Bayer paclitaxel-coated angioplasty balloon or PACA-cath, and as the Admiral had not been available at that time. This is just an example of a actual patient within the trial. You can see multiple tandem high-grade stenotic lesions. Some of those are calcified. After TurboHawk was performed with the LXC device here, you can see that there's a pretty good luminal gain there. It was finished with balloon angioplasty, with drug-coated balloon therapy, and that was the final result. You can see there's some 10% residual stenosis, and by 1 year, maybe 20. But this was an example of one patient that was in the arm with pretty good results. So if you look at the baseline clinical characteristics between these patients, you know, pretty much kind of consistently the same things that we typically see in most of our peripheral arterial patients. There's really no difference between the groups as well in terms of their Rutherford clinical category. When it comes to the baseline lesional characteristics, there were some changes, though. So if you look at the lesion length, it certainly was, you know, against DART with being a little bit longer lesions in that arm, as well as in the severely calcified arm. And if you look at the calcification as predicted, there was a little bit more of course, in the DART severe calcium arm, since that's what it was focused at, almost 90%, versus the other ones that were quite a bit less. If you look at the technical success, this is basically defined as trying to achieve less than 30% residual stenosis after your first therapy. So that means in the directional atherectomy arms, that was after mechanical atherectomy. As for the DCB arm, that's after your initial predilatation with the balloon. The bailout stent rate, there was a few in the drug-coated balloon trial, but you can see that the dissection and the flow-limiting dissections, either class C or D, was pretty high, about 19% in the drug-coated balloon trial, with the others were pretty low. And this shows you the percent stenosis at 12 months. As you can see here, the orange is the DART and the blue is the DCB. Pretty low rates of, this is actual diameter percent stenosis at 12 months. And the first bracket is all patients, and then you can see that the second one is patient lesions that were greater than 10 centimeters. So it kind of shows you that, you know, you're able to have still a pretty low grade of diameter stenosis at 1 year in your longer lesions, and then the severely calcified vessels were, of course, higher as predicted. If you look at the duplex ultrasound and the patency at 12 months, you can see that all patients across the board was about 93% versus about 89.6% in the DCB arm. But really, no difference, maybe even slightly better patency rate in the DART arm in those lesions that were greater than 10 centimeters. Also, again, showing you evidence and proof that, you know, this is maybe a good strategy perhaps for your long lesions. And certainly in the calcified vessels, it was 70% versus 62. And some of the calcified vessels that you can tease out from other trials will have patency rates of about 50% or less for severe calcification. If you look at angiographic patency, this is, again, pretty good in between the all patients. The lesions that were greater than 10 centimeters had a 91% angiographic patency at 12 months. Of course, it was definitely lower in the severely calcified arm. Clinically driven TLR between the DART and DCB arms were similar at about 7%. There's really the deaths that did occur in these two were due to CHF and cancer, had nothing to do with the peripheral arterial procedure. So what's the impact of lumen gain? I think that's another important concept here, is that, you know, the orange area shows you the significant improvement in directional atherectomy, causing a significant lumen increase right after this. And this does equate in terms of your 12-month patency. So if you look at the orange block, these are all patients that received DART. The patients in the orange actually, after their atherectomy, had plaque burden rates of less than 30%. Those did better at 1 year. Again, showing you that if you do diligent, good atherectomy, your patency rates are going to be higher. So in conclusion, I want to reiterate this was a kind of hypothesis-driven trial, and it is a pilot study similar to LEVANT 1 and to, you know, the initial impact. I think this is definitely a place where Medtronic's going to try to put their money and possibly go into getting better data for us in a larger trial. Where I would use this in my practice is certainly patients that have longer lesions that are, you know, more than 10 centimeters, those that are significantly calcified. I think that, you know, again, as we've said up here at this podium, I think folks have said, try something different. So if you have a patient you've done an atherectomy on before and they come back, do something different. Add the DCB. I think there is some good data early on here that can certainly show you there's some good patency. So with that, I think we'll finish up here and head to lunch.
Before we adjourn, I just want to make one announcement. I wanted to alert everyone of the ongoing symposium at the lunch break, sponsored by Medtronic, redefining expectations in the SFA, a critical review of the IN.PACT trial and drug-eluting balloon. And I want to, on behalf of Dr. Montero-Baker, I want to thank all of the panelists and speakers this morning. Thank you all for your attendance and your patience. We're a little over time, but I encourage you to attend this afternoon's session, which will reconvene at 1:10. You've got a great atherectomy session, and then I'm sure it'll be a very lively discussion on complications and disasters. So welcome you back at 1:10. Thank you all.